Okay.
Testing, yeah. So good morning, everyone. It's my great pleasure to welcome you on third TTX New Nordics conference. I'm Sven Parkel. I'm General Manager in Tartu Biotechnology Park. Today's event is also part of the week full of events called Estonian Health Tech Week. If you want to see what we're doing tomorrow and also Friday, then please Google Estonian Health Tech Week and you can find the other events as well. Without further ado, I'm inviting on stage for the opening words Minister Karmen JOLLER from the Ministry of Social Affairs. Please.
Because all kind of innovation and technology has been an integral part in medicine. And this is what has always given us new treatments, new methods, new science. When I was a little girl, I think I was 12 at that time, there was a morning when my mother combed my hair and made some braids. And then I was reading, at the same time I was reading a children's newspaper, which was called Säde, the Spark. And there was a news. Estonian scientists had put together a computer, personal computer, Juku. I told my mother, wow, there is a personal computer. Finally, there is something that gives me all the answers to all the questions I have. Little did I know that, at least at that time, computer was something which depended wholly on the knowledge of the user. Maybe in 5 or 6 years, I first also tried some coding. The language was BASIC, one of the simplest languages in programming. And then maybe some more years, and I met internet the first time. I had the same thought, wow, now I have something that gives me all the answers to all the questions I have. But it didn't. Again, it depended on my knowledge, how I search information. 2 or 3 years ago, I first met AI. Wow, again, there is technology that gives me all the answers to all the questions I have. And again, I discovered that, well, I have to be very smart to use it smartly. This is how technology has developed and has been very normal part of our lives. Nowadays, we cannot imagine our life without computers, internet, and now even AI. I used AI to say what was the first year when Estonia started with e-governance. It was 1997, says ChatGPT. I hope I don't make any mistake now. But yes, the first services in Estonia were started already back then. And nowadays, Estonian citizens don't imagine their lives without any e-service or e-governance, or actually e-health too. In Estonia, we have been pioneers. And one of the best things, I think, we have done with our legislation is data protection. We have protected our data so that every person who trusts their data to government or to healthcare or any other system in Estonia, they can be sure that the data are not misused anyway. For example, in the ministry, we have discovered that actually this good thing, which has really gained trust in Estonia among the citizens. We actually also see that it's hindering usage of data for scientific purposes, also for technical purposes, also for administrative or financial purposes. So we have gained trust with our very strict data laws, and I have been talking with many people from other countries, and this has actually been the biggest problem, because if you don't have the strict laws, the people don't trust government or institutions with their data. And now we are redesigning our legislation to be a little bit more open. But you will have, or actually you already have had, many interesting discussions about health, technology and innovation. We are really looking forward to many innovative solutions also here in Estonia. We were pioneers, but in many ways other countries have already passed us. And we are very happy that we also have a lot to learn from other countries, from the scientists from other universities, and from the practitioners from other institutions. I'm very happy that you are here together discussing all the things that we could consider very normal in maybe already in 5 years. And maybe you will make some very good initiatives to cooperate in future, so that we all together can achieve something bigger. Thank you. I wish you luck.
Many thanks again to Minister JOLLER for the opening words. We are now continuing with the first panel, which includes also a keynote speak. And to introduce the panel, I am inviting on stage Mr. Jaanus PIKANI, who is moderator for this session.
Thank you very much, Sven. And I'm really glad that we have so many high-level and sort of experts here gathering. Our first session is called Opportunities and Challenges. And in our recent history, like last 100 years, August has been a very challenging month. If we go back, for example, to August 23, 1939, when Molotov-Ribbentrop Pact was signed, or 1945, Nagasaki nuclear bomb. If we look at 1968, 23rd of August, where we had Soviet troops invaded Czechoslovakia. And then if we get the more recent history, Estonia got re-independence also in August. But there was also more sad and alarming sort of events in 2008, where Russian troops were invaded as a first sign of the new geopolitical sort of thinking to Georgia. And now we are in 2025, and again, we have quite alarming. So this actually sets us quite a environment where we have been talking about new technology, new ways how we can solve the societal problems, but suddenly we are in a totally new situation, which even more puts us constraints. But happily, we think we have new tools, new initiatives like European Health Data Space. We have AI, which gives us new opportunities, but obviously also new risks and challenges. And if I may get the new, my slides, please. So it seems that there is a lot of trouble all the time. People are working hard, and there's no brighter future ahead. We have aging population. We have more and more people with chronic diseases, which puts our health and welfare systems on a very strong constraint. And how we can gonna solve this? But luckily enough, there is actually a young boy who is looking somewhere ahead, and this slide is actually borrowed, and the idea is borrowed by Lars. Thank you, Lars, for this idea. And there is suddenly something new on the horizon. So you have to recognize the new opportunities, and usually the younger generation is good at it. So I hope we can actually today discuss these opportunities, and we can actually see something more bright on the horizon. And that's why I'm happy to open this session with Mélodie BERNAUX, she's actually unfortunately was not able to join us today physically, but Mélodie will give us a first keynote from the view from the European Commission online. So, do we have Mélodie? Yes. Yeah, thank you. Thank you. Good morning, Mélodie. Happy to have you here, and floor is yours. Okay. So, sorry, Mélodie, we have some technical problems. We need something to set here, some kind of problems with the voice. Sorry for that. Yes, as you see, technology can help you, but also can hinder. So let's hope that we can. So meanwhile, we can actually. Yeah, this picture is actually by a painting by Ilja Repin, and we have people and good representatives from Finland. So actually, Ilja Repin spent his last days in his life, and most of his life actually in Finland. So, okay, thank you. Can you put? Hi, Mélodie. Now we are ready to go. Thank you.
You can hear me properly
Yes,
this time?
much better.
Well, wonderful. So good morning, everyone. Thank you for having me. It's, of course, a pleasure to join you, although it's only online. Of course, I would have loved to be in Tartu with you. I think it would be for next time. You know, we are making efforts in the Commission in greening our travels and missions, so we try to travel less. But hopefully next time. So this morning I wanted to explore a little about the European Health Data Space, how it interacts and how it's important for our European innovations. When we speak about AI or personalized medicines or digital therapeutics, we quickly jump to algorithms, device, regulation, application. But beneath all of this lies something simpler and much more fundamental. It's the data at the core. The quality of our innovation can never exceed the quality and accessibility of the data that fuels it. And of course, you know, in Europe, we are still scratching the surface of this, although we have many data available. So we know that Europe holds some of the richest health data sets in the world, decades of longitudinal registries, electronic health records, imaging archives, biobanks, genomic repositories, but too often they are fragmented and hard to connect across borders. In practice, it means that researchers may spend months negotiating access in other member states. Digital therapeutic startups may struggle to validate solutions beyond its first country. Even public authorities sometimes lack timely comparable data for core tasks like workforce planning or tracking inequalities, and we saw that during the COVID crisis. The opportunity, the cost for patients, for clinicians, innovators is huge. And as you all know, probably this is the problem that the European Health Data Space is designed to solve. Of course, in the European Health Data Space, you have primary use of health data, you have certification of EHR system. But for me, when it comes to innovation, the real breakthrough of the EHDS is the secondary use of health data. For the first time, Europe will have a common, safe, and legal way to unlock the potential of health data beyond direct patient care. This means that data collected every day in hospitals, clinic, registries across Europe can fuel innovation across the spectrum. For research, it means accelerating discoveries and clinical trials by giving scientists access to richer and more diverse data sets. For policymaking, it means enabling ministries and public health authorities to monitor health trends, allocate resources, and design evidence-based reforms. Innovation and industry, supporting the development and validation of AI models, digital therapeutics, and medical technologies that are safe and effective. Overall, we see that this designs what we call a self-learning health system, where data from real world use feeds back into care, better care, more personalized medicine, and continuous improvements of our health system. In short, EHDS aims to turn today's fragmented data landscape, full of uncertainty and inefficiency, into a predictable, trusted framework that transforms innovation and information into impact. And you are well placed to know that we know this is feasible because in some parts of Europe, some people already do it. It's the case of the Nordics and the Baltics region. You have shown that responsible use of health data is not only possible, but it's already delivering results. I'm thinking in Finland, the Cancer Registry has supported population-wide research since I think the 50s, and initiatives like FinGen combine genomic and health data at scale. Since 2020, FinData has gone even further, acting as the one-stop shop for secondary use requests. Exactly the model that EHDS is trying to generalize at European level. In Sweden, more than 100 national quality registries provide detailed longitudinal data on treatment and outcome. This is so rich. They are integrated into daily clinical practice and have proven how registry-based research can directly improve care. In Denmark also, the unique personal identifier enables robust linkage across registries, making the country a leader in real-world evidence and health system planning. This linkage logic has also inspired the ESD old approach to dataset and data description. In Estonia, of course, the health system has given citizens not only access to their records, but the ability to see who accessed them. A powerful transparency norm that directly influenced the HDS transparency portals and use in primary use. Across the Baltic Sea region, in Nordics, we see projects like the BALODE projects, who I was very happy to discover. And with such projects, you are already piloting cross-border infrastructures, examples, coordination, showing how digital frontrunners can anticipate EHDS and move faster together. So EHDS, and especially secondary use, is not an abstraction from Brussels. It's the translation of your living experience, the living proof, as EHDS learns from this European excellence and scales it to the entire Union. It codifies what has worked nationally and regionally and makes it the European standard. Of course, none of this will work without trust. That's why EHDS embeds 3 non-negotiable safeguards. Transparency, since students can see who accessed their data and for what purposes. Choice, citizens have the right to opt out of secondary use and sometimes from primary use. Security, when it comes to secondary use, data stays in secure processing environment. Researchers come to the data, not the other way around. And of course, we have independent authorities such as health data access bodies who provide an oversight. This is how we balance fundamental rights with genuine innovation in Europe. Now the key is how do we move from vision to practice and where do we stand today? As you probably know, the regulation was adopted in a very, very quick way in 2024, only 2 years after the proposal was made by the Commission, because of the great involvement of all the member states. It was published in the official journal in the beginning of March 2025, and it entered into force at the end of March 2025. So now we have a staggered application phase, and we need to move forward. Implementation is advancing along 3 tracks. First, building and shaping the infrastructures, both at European level and national level. It means building the Health Data at EU infrastructure for secondary use and expanding My Health at EU for primary use. We're also working on implementing acts, that is, operationalizing what is in the regulation into clear rules that make the system work. That is, how do we describe data sets? What are the technical specifications of some aspects of the infrastructure? And all of this is starting to happen. And of course, a fundamental layer, the governance. At national level, establishing digital health authorities for primary use, health data access bodies for secondary use, and in every member state, and ensuring EU-level coordination through the EHDS board. We are looking at 3 major dates. So 2025, we are there. We know that before the end of the year, we will have adopted the first implementing acts. By 2027, we will have established the EHDS board to steer the coordinated rollout of all the provisions of the regulation. And by 2029, all member states must be connected to the 2 infrastructures, Health Data at EU and the renewed My Health at EU. These steps are not only institutional housekeeping, they enable concrete progress of innovation and Europe flagship priorities. How does this translate in the new priorities of the Commission? First, cardiovascular health. The upcoming EU cardiovascular health action plan. Maybe you've heard about it. I can share the link in the chat after. There's a call for evidence for this cardiovascular action plan. It's open until the 15th of September. The plan will be announced hopefully by the end of the year by the Commissioner. And it raises the bar on an earlier detection, personalized care, and outcome monitoring. Data, AI, innovation will be at the core of the plan, transversal pillar. And EHDS will provide the baseline infrastructure to link cardiovascular datasets across member states, so AI models can be trained and validated at a clinically meaningful scale. When it comes to cancer, you know, cancer has for long been a priority of the Commission in health. The Cancer Mission and the European Speeding Cancer Plan needs also large and diverse data set to accelerate screening and treatments. EHDS will work hand in hand with the other projects already existing in cancer to make registries and imaging datasets findable, accessible under harmonized conditions, replacing months of bilateral negotiations across member states with a predictable and transparent pathway. When it comes to AI and digital therapeutics, you cannot ignore the forthcoming Apply AI strategy that will be announced in the fall. It will emphasize that Europe must not only regulate AI, but enable trustworthy adoption. And EHDS is the backbone for the Apply AI strategy in health. It defines allowed purposes, sets the secure environments where development and validation occur, and bakes in safeguards that clinicians, citizens, researchers, all of us can trust. For innovators, this reduces uncertainty. For patients, it means safer access to solution. And for AI makers, I would say, it means faster access to the market, faster proof of that their solution work. For the Apply AI strategy, the call for evidence will be launched. No, it's not a call for evidence, sorry. It's a public consultation. It will be launched, I think, by the end of August, beginning of September. So stay tuned if you want to contribute. As you can imagine from my speech, I think I'm a strong believer the Nordics and the Baltic region has a distinctive responsibility in the implementation of EHDS. First, as a locomotive, you pioneered cross-border use cases. You need to continue. You need to test, to front-run, to demonstrate how transparency, how secure processing environment, how federated learning, how all of this can work in practice. And that's what you are already doing with projects like BALODE. And I strongly encourage you to demonstrate all those use cases at the regional level so that they can scale in the EHDS. You have a second role as a mentor and capacity builder. You can help member states with lower digital maturity adopt workable governance, metadata, and secure processing models, share code, playbooks, best practice, lessons learned to shorten Europe's collective learning curve. And I know that's what you are all doing with your participation in the health network for primary use and the community of practice for secondary use of health data. And I encourage you to continue. In short, your achievements inspired EHDS, and I'm a strong believer you can ensure it delivers and scales up across Europe. My message today is simple. EHDS is your chance to unlock health data-driven innovation at scale for all the European priorities, for all the European citizens, for cardiovascular, for cancer, for AI, digital therapeutics, with trust at its core. It's our European fundamental value. So help us move from regulation to reality, continue to be the locomotive and the mentor of Europe in digital health so that by the end of this decade, every patient, clinician, researcher, and innovator can benefit from a truly European health data space. If we succeed, we will have built more than a framework. We will have built a healthier, more innovative, and more resilient Europe. Thank you very much.
Thank you very much, Mélodie. It was excellent, sort of setting the scene for today's discussions. And really, as you said, we have, as a region here, quite important role, and there is very high expectations from other parts of Europe. That's why we are here, and the actually title of this conference is also New Nordics. So it actually very much demonstrates that we see this region as a one, although from ScanBalt as a meta cluster, we have seen it already 25 years. As the name ScanBalt actually indicates that we see this and Baltic Sea as a uniting actually factor. So that's why I'm happy to invite here representatives of this region. We'll start with Nele, which is a representative from the Estonian Ministry of Social Affairs. Then we have Daniel, from Vice Minister for Lithuania. Sari, Finnish Ministry of Social Affairs. So I'm happy to have here. So, and of course, Aiga. Where do we have Aiga? Aiga is there. So the Deputy State Secretary from Latvia. So, and Michelle, of course. Michelle, who has today quite important role in this panel and also in the panel afternoon to fulfill. So thank you for being here, and I hope that Mélodie can also actually join us. Can you also switch her on? So we we started, and we discussed earlier, it's not secret, we have prepared for this panel. And we actually plan to start with a short round table, and each panelist can actually present shortly where their particular country stands at the moment, and what are the next prospects and strategies for the future. So perhaps we start with Nele here, as we are host country.
Hello, nice to meet you all here in Estonia. I will start with a short introduction. I tried to put everything on one slide as it is and how it could be.
Can we have a Nele slide? Next.
Well, I could speak about Sweden as well.
Next. We have some mixed here, but let's go to next. Oh. Yeah. So we have some problems with.
Okay, I believe I might remember what I wrote on the slide. I wanted to make a picture of what is achieved here in Estonia, what is in progress, what our challenges are, and what are the opportunities for the region and Estonia within. Well, about achievements, I'm humbly happy that we have reached the maturity level of 100% together with Belgium in European Digital Decade. Also very happy that already since 2008, Estonia has one single healthcare portal for all patients. All the data of healthcare is in this portal, and we all can see it. We all can also close the data there. So access to it is granted. We also have almost achieved most of the EHDS goals for 2029. Some little bit work still to do there. And happily, we have e-health strategy to navigate us through everything. What is in progress? I would say that what I'm most eager about is I hope to introduce in January the first national genome-based service, healthcare service in Estonia, which will be breast cancer scanning. So last efforts to be made. Technically and medically we are prepared, so legally now only. Also in progress, we also have, together with all the stakeholders, creating a innovation roadmap for all our startups, all our health tech companies to navigate to the difficult systems that we all together have made up. Let's go to challenges. Well, cybersecurity. The number of cyber attacks has been steadily going only up. There's no way it's going down, so we have to be more and more and more prepared all the time. Data quality. Always, we have data since 2008, digital data. I think you all understand the variations of the quality within that time that have been introduced there. So this is a constant collaboration and the main goal of the strategy for 2030. Oh, good. Now I remember what I wrote. And well, let's go to opportunities. I won't take up everyone else's time. I think as each of Nordic and Baltic countries, we can be very good sandboxes, but probably we are a little bit too small to prove to the biggest countries in Europe that yes, everything is possible. So I think the most important opportunity for us is to make collaborated efforts and pilots and show that all this is possible for everyone in Europe. And also I added one last point there, under opportunities. Estonia has collected more than 200,000 genome data of our citizens, and we have already enriched it with health data from 2008, basically. Why did I put it under opportunities? It's done. We most certainly underuse it. There are so many more possibilities that we hope to make something greater of this with good neighbors. Thank you.
This problems. So let's go to the next slide. Let's start at Lithuania.
It's mine. Yes. Yeah. Thank you. So thank you so much for the invitation, and it was so nice to hear from the presentation from Mélodie. It was like a melody for my ears that Baltics and Nordics are so great in the data, and I'm so proud to be sitting next to a colleague from Estonia and Finland because they are one of the best in that field. So I'm really proud to be part of the Baltic-Nordic region. So speaking about Lithuania, we have a national e-health system from 2016, and as you can see in the graph to the right, at the beginning we had like around 300,000 electronic health records, and last year we had 110 million per year. So it's growing steadily and it's being used a lot. Our national health system has referrals, outpatient visits, laboratory reports, e-prescriptions. We are one of the countries in the European Union who has e-prescriptions that being used in different countries, in 8 countries, and like Baltic and Nordic, and also like Spain and Portugal. Our patients our citizens can buy medicines in different countries with the e-prescriptions. Death certificates, birth certificates, health certificates for drivers are being also reported there. Discharge summaries, obviously everything about COVID and vaccination. And speaking about secondary health data usage, we are also proud that in 2021 we have created a law, and it became live on 2022, and it's being used. So all the citizens in Lithuania are being part of the health. It's an opt-out solution, and our researchers and private sector are using this opportunity to get that data. But there are also some of the challenges, if you can move to the next slide. Speaking about secondary usage of data, it's obviously standardization and structurization, like everywhere. Some of our hospitals have their electronic health records since late 90s, and obviously then there were no such standards, and even now some hospitals in different departments have different standards. Well, if we want to have in different hospitals in the same country, it's harder, and if you have the same standard in different countries, it's even harder. But I believe that it's an amazing idea to create this one e-health for European Union. Overall, European Union is about standardization. We know that. We try to standardize everything, like even money, you know, the currency, everything. And this is one of the parts, and I'm really proud of the health data spaces, beginning from the health overall data spaces, but beginning from the health data space. So our main challenges are obviously the resources. If we need to standardize, structurize everything, and to make a lot of legal changes, we need a lot of resources, human resources first of all, and later our health institutions are scared if they will have to make fast changes in their systems, because it's easier to make changes in national system, but to make changes in different hospitals, and we have like 800 different institutions, health institutions who collect and share data. So it would be harder. Also, we are a bit skeptical and concerned regarding the opt-out. Obviously, European Union is ethical, and it should be, but it could damage, research and innovations. And that's what's happening already because of the, discourse word GDPR, that we are losing in innovations compared to US or China. And I hope and I believe that European health data space could help with that, help innovators, scientists to do more. And maybe more I will tell during the panel discussion. Thank you.
Thank you. Let's go to the next slide. So Michel.
Thank you, and thank you for the invitation. I'm very glad to be here. And just to give you a Swedish perspective, so I'm at the Swedish e-health agency, E-hälsomyndigheten in Swedish. So if we jump to the next slide, please. We see that we have a proposed roadmap for a national digital infrastructure. And the thing is, we have very much of this in place already, but it's far from truly national, so it's not available for all healthcare providers and other stakeholders, of course. So since a couple of years back, it's very clear that the Swedish government now is ready to take a main responsibility for infrastructure. And that's a new thing, because up till now, that has been a distributed responsibilities for, especially I would say, the different regions of Sweden, also to some extent for the municipalities as autonomous entities responsible for healthcare and social care in Sweden. For better, for worse, maybe, depending on which perspective you have. So the government has now stepped up and also given government assignments, especially to my agency, regarding investigating and preparing and start building this truly national digital infrastructure. And the aim is, of course, that it will be available to be used by all stakeholders, and in that case, mainly at this point for primary use of health data, but hopefully also for secondary use of health data for research, innovation, etc. I think we will get back to that later during this discussion. And of course, it also needs to be aligned with EHDS, the EHDS regulation and the requirements. So that is a clear goal with this work, of course. If we go to the next slide, you see here, hopefully, and collaboration is crucial in this case, of course, both nationally and also cross-border. Here you see a simplified chart or picture of this national digital infrastructure with the different stakeholders, or some of them at least. National contact point, NDI is the national digital infrastructure for this sector. And then, of course, you see the connection to the European health data space in that case. So I think we can move on to the next slide, the final one. And I was happy to hear that Mélodie BERNAUX from the Commission in Brussels, that she mentioned this VALO project. And VALO stands for Value from Nordic Health Data. And it's a project preparing for EHDS jointly by the Nordic countries, preparing for EHDS with a special focus on secondary use. And it's led excellently, I would say, by the Finnish Innovation Fund, Sitra, which by accident, or maybe not, also leads the TERAS2 project that most of you, or maybe all of you, know about already. We have, for instance, Elina Drakvik here from Sitra. And I'm also very glad to see that it's not only the 5 Nordic countries collaborating within this VALO project, but also at least 2 of the Baltic countries, that is Estonia and Lithuania, as observers from now on. So we still have one more. We've had an extension approved, so we have 1 more year now to work further on this. And actually, we will meet in the project in Reykjavik next week to continue the discussions on the Nordic or new Nordic, extended Nordic level, how to develop further the collaboration when it comes to EHDS or EHDS2 preparations. So with this, I think I say thank you and give the word back to you. You can take.
Thank you.
I'm not sure if there's a last slide, but I give the word back to you.
Jaanus. Thank you, Michelle. And let's see. So, Sari, I'm happy to give the floor to you. So.
Thank you so much, and good morning, dear audience. Good morning, dear colleagues and friends. So I'm really happy to be here today, and thank you for the invitation. And I just wanted to start about the Finnish situation, echoing what your Minister of Health said. And when we think about Finnish perspective, and if we can say that we have been relatively successful with many initiatives, it's closely coupled with trust. If we think about secondary use of health data, that was very, very visible for us that we could get such a new legislation through without any major conflicts with the population. So I just want to stress that within Nordic and Baltic countries, our starting point with strength in trust is such a huge competitive advantage that the other countries not necessarily have. But now I would like to set a little bit the scene with the Finnish situation, and I wanted to just to show you that we were kind of early beginners. We have relatively long history with digital health initiatives, and already 2007 we had the major e-health legislation, and after that we deployed e-prescription system, also having fully digital electronic health record systems at hospital level, and then we built up also national Kanta system portal, which you can access everywhere from country. And then on top of that, we also developed, for instance, patient portal. And it is one of the major brands, Omakanta, in Finland. So it has been really successful. And I really want to mention, when it comes to European initiatives, that Estonia and Finland were the first countries that started operations with cross-border e-prescription already 2019, and after that we have had very fruitful and close collaboration. And there is much more around these issues, but for the sake of time, I just want to stop on the point on EHDS regulation. So it's of course the crucial game changer for all of us. And now what I'm saying, I think that we share with Janika Merilo from Ministry very well this issue that the coming 2 years, as we are representing our country in the EHDS Comitology in Brussels, it will be deciding all of the implementing rules regarding European health data space. As you know, the regulation itself, it doesn't define everything. And within these 2 years with the major implementing acts, there are the opportunities, but there are also the challenges, if I put it in a nutshell. And there we really need large-scale involvement in Nordic and Baltic collaboration, that is for sure, where we can share with our mature digitalization level, we can share some ideas, since, as you know, the regulation framework as such, it's very tight alignment when it comes to standards. And that is, for instance, for us that were early beginners, that is posing some challenges. Changes are needed, for sure. I know something about that, but that is also connected to the financial challenges on national level. But still, within these 2 years, we have an opportunity to have an impact with the close colleagues in EHDS Comitology. And that is my key message here when it comes to the future. And now the final wrap up. So the Finnish situation. So this is also why I took these elements on the slide, since these are also the eminent collaboration areas. Of course, we have on national level other types of initiatives, and we are stressing, for instance, digital inclusion. We didn't make it so well as, for instance, Estonia and other countries in the Commission comparison. But still, I want to focus on the secondary use of health data. That is where we have already existing collaboration with secure processing environment, for instance, with Jaanika and colleagues. And there is much more, for instance, AI development, innovative approaches, and then age technology is among our key areas. And then what we are now developing with my colleagues at the ministry, it is also a kind of expert service for all health digitalization issues. We have long history with interoperability factors and things like that. That is always being asked from Finland. So we want to standardize a little bit this approach to be able to collaborate a little bit more effective way. So these are maybe the key elements here for Finland. Of course, there is much more, but all in all, when it comes to future, we are very positive and we see lots of opportunities, even though try to be realistic and foremost collaborative in order to benefit all of our efforts. Thank you. Over to you.
Sorry. Thank you so much.
Don't need it.
So do we have another slide? No, okay. So, but nonetheless, we have now floor for Aiga, so without slides, but I think you have everything what you want to say you can do now.
A very good morning, and imagine what it is sitting here, not seeing anything behind the screen. Imagine you see something wonderful pictured there. And therefore, I have a question for you. Do you dream? Do you ever dream? And if you dream, I wish you would have taken an early ride with us from Riga this morning. Well, the clouds were pink, and the golden sunbeams were going through. And there were only a couple people all the way through that we met on the streets who were passing by our car. I have another question. Do you learn? Do you learn regularly? And then the most rhetoric question for me, do you relearn? Do you put away your old luggage and start from scratch? Now, this is the reason why I don't have a slide. I've taken with me all I have in Latvia regarding digitalization. My team members are here, and I am happy, being a dreamer, to see that we finally have an institution in Latvia dealing with health data. Last year, starting with a team of 5, today 70 people in our digital health center, and their boss is sitting here. So what's going on, how we are dealing, you have firsthand to visit jurists and ask the questions. And he had the hard time because he had to start telling people that digitalization is not about AI, is not about IT and AI. It's about transforming, reimagining healthcare, looking at services from different perspectives. And that's not an easy job. I remember him fighting for fire standard and trying to explain other institutions why we have it and why he is not going to give up on that. And I think sometimes I should have my camera to make those faces. And next month, we are expecting already the first training course on fire standard. We're submitting to our government's NOMAD international opportunity to join. And it takes time and it takes efforts, still different in different countries. But what I wanted to acknowledge today is the enormous support we have received over the last 3 years for sure. There are only 2 other things that I would like to highlight. One thing is currently the biobank law that has been submitted to the parliament already for the 2nd reading. So in autumn, we finally will have a biobank law. And you should have seen our Lithuanian colleagues made an on-site visit possible within 3 minutes, just like that. You ask them, you have the opportunity. The same for Finland. Couple minutes, when can you have online access to our knowledge? There it is, take it. When can you take it? So sometimes drafting later than everybody else is better because you can learn from mistakes. So we have also finally drafted the secondary data log, it goes slow because our legal colleagues ask us, why do you burden us twice, now with this law and then with European Health Data Space? But I think we learn from each other very much, and we should appreciate it. Now, why I ask you, are you dreaming? When I come to gatherings like this, it's very easy to talk because we're on the same wave, we see horizon the same way, but I have in my portfolio 2 assignments. It's digitalization and change management. And then I like to go to a local hospital, to a local service that provides healthcare services, and to see what they understand from all of the wonderful work we do here. And I guess I have to admit that somehow I agree with OECD recent study on Does Healthcare Deliver? That it says for patients, there are only 3 that matter, and you probably know it. It's timely healthcare service, it's tailor-made, and it's trouble-free. Believe me, my colleagues, doctors, and administrative staff in healthcare authorities, they ask for the same 3, and they are enormously hard to deliver and even impossible unless we work together. And today, what Mélodie said really also just warmed my heart that it's worth learning, relearning, and dreaming that Latvia can do. Thank you.
Thank you. So, let's start now our discussion, and we take later the questions from audience. So, as we have started discuss, and it has already said, there is a primary healthcare data use and a secondary data. And we have had a preliminary discussions that sometimes there might be some conflict on priorities when one institution has to secure both. If you look for the healthcare providers' point of view, obviously the primary healthcare, primary use is more important. But if you look from the sort of helicopter view and from the outside and from researchers' point of view, from industry, then the secondary use is important, then policy making. So how you see this? Maybe we can start with maybe Daniel's, because we had Daniel because we had some discussion earlier, and Michelle and the others can of course then continue.
Yeah. So first of all, like before becoming a vice minister, I was a scientist. And as a scientist, I needed data. And that's why I love the secondary use of the data, even more than the primary. But right now I am responsible for the Ministry of Health. So primary is even more, it's important right now. So the main thing is that for hospitals, they don't care about the secondary use if they don't have like university affiliation or biobanks, for example, because then they can standardize, structurize that and reuse it. Overall, they don't care, they don't want to invest into that, and even they don't care about the standardization, structurization overall, because if they can speak inside their hospital with their electronic health records, it's enough for them. But I do believe, as I mentioned before, that standardization overall in everything, in every field is important so that we can speak on the same language. So how we see it as a Ministry of Health. So we want to make if the data will be collected perfectly, like standardized, structurized for the primary use, then we can use it for the secondary use even easier. So our strategy right now, like our government strategy, is to work more on the data. We have a prospective and retrospective data. For the retrospective data to like structure and standardize it, we definitely need some AI tools. But Lithuanian language is hard. There is a lot of free text, and free text has personal information, so it's harder to standardize. For that, we believe that there is needed to have investments for projects to standardize that. Speaking about prospective data, we do have a strategy that we are planning to invest into with our state health insurance, so that the hospitals will get higher payment if they are collecting and giving data to our national e-health system according to the standards and structure. So that's why we'll we won't give them money straight away, but we will say, if you do correct, then we will get more money. So that's the strategy we are developing right now. We don't have it yet. That was just my idea when we started. Like, our government started only this year. So if this will work, then we can at least have prospective data collected perfectly. Speaking about retrospective, definitely we need more investments, project investments, and probably there should be collections for separate diseases, for separate populations, and I believe that biobanks could help on that, because biobanks are like there from the 90s, and they have already strategy on how to collect data, how to do it ethically, and not only data, but also samples, which later become data. So that's my point of view.
Thank you. Michel, how is the view from Sweden?
Oh, that's a tricky question. I was hoping that you would ask for my view on this, but anyway, trying. To start with, I agree very much with what Daniel said, and if we're talking about primary use of health data, that is, of course, for healthcare today, and secondary use is for healthcare tomorrow, or even further in the future. And both are important, of course. At the same time, it's a question of priority when it comes to resources, at least. And looking at Sweden, regarding the responsibility on government level when it comes to EHDS and the EHDS regulation, that responsibility is on my ministry, which is the Ministry of Health. And again, that is for better and for worse, maybe, because research matters, for instance, is on a different ministry, of course, and also when it comes to enterprise issues, that is, again, on a different ministry level. So, and the important thing is, of course, and a challenge for the different ministries to really communicate and to have a clear government, joint governance when it comes to this, for primary use as well as secondary use, of course. Personally, and I think I'm also in a way speaking for the Swedish government, we are happy that actually the EHDS regulation covers both primary use and secondary use. And I know that during the negotiations, which actually I took some part in, there were some discussions. And I know that some countries maybe wanted primary use and secondary use to be split up in different regulations. I think it's a very good thing that now the same regulation covers both, actually, with all the challenges that comes with that, of course. I think I'll stop there.
Thank you. Thank you. So who wants to continue?
Maybe I could add some points. From Finnish perspective, we very much, of course, agree with different things that were said already, but the thing is that in Finland we are in a situation where we are trying to achieve a new vision for primary use of health data and secondary use of health data. Both areas have been invested heavily, but the question is on national level, since we have our history with Kanta services, national layer, so who is doing actually what? So what is the role of regions when it comes to primary use of health data, and how much space for innovation there is also to enable, for instance, companies to be part of this innovative path on the hospital level, for instance. But then there is another aspect that from my perspective, I cannot see primary use and secondary use a totally separated area, but they are closely interconnected. And just lessons learned from Finland that since we are early beginners and we based our approaches on interoperability, that we started to that approach where we standardize very heavily on national level. So it isn't necessarily easy to convert our approaches to that way that would enable, maximize the easiness of secondary use of health data. I am talking about, for instance, open EHR approaches and things like that, that are kind of a uniform approach for every partner, so it isn't necessarily easy for easy adopters. But those that are more in the beginning of digitalization journey, it should be heavily recorded what is being done on primary use of health data, since like Michelle very well phrased, it is the future of healthcare that is around secondary use of health data. And of course, when we think about data, it is like, you know, bread and butter with the AI development. So in that sense, it's really, really important issue to enable the usage of data from the very beginning.
Thank you, Ms. Aiga. Please.
If I may just add to what Sari said, we are talking currently about treatment and treatment data, but we all strive for prevention. And then question comes, what about self-declared data? If we see so many apps and so many technologies have developed due to this health uncertified data, and they are ready to provide their services, and we hear that people are willing to provide their data for prevention, for better care, and that's something else that adds up and maybe just adds more pressure on us to provide the classified, standardized primary data that leads to secondary usage of the data. But I would say that we can't not reflect also on this, that people are asking, when will you finally all agree how you take my data for prevention and so on. But it's so very important that question about data accuracy is in the mind of us all, not correcting back or looking how my colleague wrote it, but from the very beginning, why is it necessary and where it leads to. We've been talking to several doctors in clinics, and then they said, well, if you would have explained where later on and how it strives into other channels and other systems. So this is again how we translate why the very single nurse in the hospital is important, because her entry, the whole system depends.
Nele.
Yes, I would add that I don't see any conflict at all in joining the primary and secondary use of data and the holder of those. In the prime principles, they are the same. The core is data quality, structure, standardization, easy approach, minimal approach, and safe usage. These apply to both. So yes, it has turned out that hospitals, as the owners of data, have been putting more effort into primary use of data and made that easier and more convenient for medical staff, and not so easy and convenient for researchers. So this is where governments need to help them. But I forgot the point I was making. What we really need to do, if the data is in the primary use, structured quality, then it's easy for both the secondary and the primary use. So it doesn't matter which way we look at it.
So actually, this is a prerequisite. If you have quality data recorded for in a primary setting, then it's actually secures interoperability and standardizations.
I remembered my point. Actually, I see a change in doctors' behavior because of some tools that we provide nationally. For example, decision-making support and the drug-to-drug interaction tools. If doctors use those tools and the data they have provided to the system is not quality, they don't get good results. So now it's not only the researchers that claim that data is bad quality, the doctors claim that their own data is bad quality. So we see a change there.
So they have been able to look to the mirrors. Mélodie, do you have any comments on this issue? If you looked on the EU level or from other member states?
I think everything I heard is very, very interesting, and mostly I agree that primary use and secondary use implementation are very complementary. each other. What we are observing from our EU perspective is that in many member states who have a certain level of maturity on primary or secondary use, until now they've been dissociating the agencies and the authorities taking care of the implementation of primary and secondary use. And we receive a lot of questions. Would it make sense to have one single contact point in the member states for both primary and secondary use? And we hear very valid arguments that this will lower the cost, this will help optimize processes, but mostly that this will ensure continuity between primary and secondary use. So I think it's very interesting to consider from a member state's perspective. And of course, EHDS is not a one-size-fits-all, so every member state has the flexibility to organize its governance and coordination at national level, and we'll be looking and listening to your different experience to help shape maybe best practice at the level of the EHDS board. And another thing I would like to reflect on is that in primary use, we see that from, I would say, the higher level, the administrative or government layer, it's very much about the ministries of health. But when it comes to secondary use, it's super important that the implementation strategy goes way beyond the Ministry of Health. It should involve ministries of research, ministries of economics, startups, etc., because it's way beyond healthcare. It has implication on digitalization at the broader level and communications, but also research, of course, and higher education, etc. And this is a strong message that we want to pass on. Please, for secondary use, don't forget to go beyond the ministries of health. So that would be my main 2 points, yes, that I would like to bring you.
Thank you. These are absolutely relevant if we hear what we have heard from other. Yes, Michel, you have a comment.
I just have a brief comment that came to my mind listening to Mélodie saying very wise things as always. But one thing is that, again, when it comes to primary use versus secondary use in a way, I think most of you know that we are preparing now for the implementing acts that have been mentioned specifically in 2 separate EU projects, which is, one is the extended EHR joint action for primary use, and the other one is the TEDAS-2 towards the European health data space, the second joint action with those efforts for secondary use. And now we have stakeholder consultations for both of these EU projects with material that will be the basis for many of these implementing acts. So those are really important. One reaction I had is that preliminary to one of these drafts on consultation. Do we look at this? In this case, for instance, it was patient summary from extended EHR. And one reaction was, do we look at this also from a secondary use perspective, or do we only give feedback when it comes to primary use? And I think that is a question that pops up once in a while working on this, that actually I think that we still have a challenge in collaborating cross-border when it comes to these different EU projects, for instance. And I know by experience, I'm mostly nowadays involved in extended EHR, that we have so much to do in that project. So it's really hard also to be open-minded to other projects' work, so to say. But I think that we need to improve when it comes to that. Otherwise, we still have the risk that we build EHDS for primary use and secondary use in separate silos. Sorry.
Thank you very much. I will take some questions here. Mélodie, you want to? Yes, please.
Yes, I want to react, and thank you very much, Michelle, for raising this. I think it's super important, and I would like to take the opportunity to flag that we need to collaborate across borders, we need to collaborate primary use and secondary use, and we need to involve as much as possible all the citizens and all the actors. We need to shape those implementing acts, not in, this small circle of EU experts, EU project managers. We need to go beyond. And those two joint actions are very, very much the symbol of this, with the efforts, the enormous efforts that the two joint actions, I can talk very fondly of TEDx2, which I'm following closely, are doing to reach out in their public consultation to all the stakeholders to gather input. It's super important. So we all have a role to relay the public consultations as much as possible, to gather as much input as possible. And this means, as Michelle said, having secondary use actors providing feedback on primary use deliverables, and primary use actors, healthcare providers, patients, providing inputs on the deliverables from the secondary use. That's also why we have those public consultations in the joint actions. Just to give you and to remind all of you how we are preparing those implementing acts. We have established a regulatory committee at EU level where all member states are represented. And I can see most of the representatives from the Nordics and Baltics are present in this room. So we will see each other soon again in Brussels. And they are working on the implementing act. The Commission makes a proposal, and based on the discussion that we have with the regulatory committee, and of course informed by the work of the two joint actions. So all the feedback that we gather during the public consultations of the joint actions on the deliverables of the joint actions will, as Michelle said, directly inform the drafting of the implementing act. Then we prepare with the comitology the implementing act. And then we undergo a second wave of public consultation on the implementing act. And then we adopt the implementing act. So we have two opportunities each time to contribute and to raise awareness to gather as much input as possible. Because the idea is not to make something that is very nice on paper and that doesn't work in practice. So just to remind you all the role that we have to relay the information and raise awareness about those public consultations. And I'm sure Alina will talk about this afternoon when she talks about TEDx2.
Thank you, Mélodie, from such an explicit explanation of the process. But now we have opportunity to actually engage. So our wider public already now. So yes, please. Who has a question? Yes? Do we have?
I have the microphone.
Yeah. Who had a microphone?
So I will be first.
Yes. Yes.
Terje Peetso is my name. I'm from the North Estonian Medical Center. Thank you very much for this good discussion. My question would equally be worth for the session on EHDS, but I take this opportunity to have this panel and the Commission official on the screen to ask my question. First of all, to Daniel, there are some hospitals who are interested in secondary use because we also use data for the quality control and for the comparison and for all these type of tools in addition to research. But as the long-term Commission official, I am very happy for the enthusiasm that you represent. But also, let me be a bit skeptical because of this experience. I am thinking, if we take the Cross-Border Healthcare Directive from 2011, we are not yet fully implemented the Article 14 about the cross-border access to e-prescription, for example. So I wonder, you are working in comitology on the implementing rules. I'm also thinking about the motivating rules. And I would really like to know how to motivate all member states to contribute and how to motivate the healthcare providers. Because it seems from some calculations that it would be rather expensive cost for the providers. And I wonder what the panelists from the member states' point of view and from the Commission point of view think about this, how to motivate. Thank you.
Who wants to actually give him? Mélodie, maybe you can start.
Yes, thank you very much for this question. I think it first gives me the opportunity to remind you that Article 14 of the Cross-Border Directive was very nice, but it was only a voluntary system that was established. So it was up to member states to choose whether they want to engage or not in what is currently My Health at EU. When it comes to EHDS, it's not a directive, it's a regulation, and it's an obligation for all the member states to connect to both the infrastructure. So I don't know if this is a motivation for member states, but there's clearly an obligation, and a European obligation that applies to all of the member states to connect. So this is different. And what does it mean from Commission side and also from member state side? It means that it becomes a priority to implement this regulation because it's a regulation with an obligation and not a directive with a voluntary system. We have all an obligation to deliver. So we are putting a little more money on the table than from the cross-border directive also. So I think that's important. And when it comes to the Commission, we can see that this money is directly allocated. We have direct grants for the implementation of secondary use and primary use to all available for all the member states. We have the wonderful joint actions. We are also building at central level the core components of the infrastructure, and we are offering them as open source components for the member states to reuse and facilitate the development of their infrastructure. So I think we have a number of supportive actions that are here that were not there for the cross-border directive that will help us move forward. But of course, it all depends on us all to raise awareness, to motivate actors. I think another important point to see is that we are not in the same situation that we were when the cross-border directive was adopted. You know, I'm a medical doctor by training. I was a researcher in Greater Paris University Hospital, so I took care of patients. I looked for data to do my research. And I don't think the situation was the same. We did not in the hospitals had the same vision of what was data 10 years ago than we have today. With the COVID crisis, everyone has seized the value of the data. And I think this creates a strong motivation from everyone across Europe to make this work. But I agree, we have many challenges to face, and that's why we need to stick up together to face them and implement it.
Thank you. Sari, you wanted to add?
Yes, maybe I could add. My friend Nele pointed out a very clever question again to the point. Yes, first of all, when we think about HDS regulation timelines, they are so strict that it poses the first challenge. But I would take a little bit from my past history with the direction of the University Hospital HUS for several years. And when it comes to the motivation for health system, maybe it is inside the patient benefits. Physicians and nurses are for patients there, and really it needs to be explained from patient perspective, what does it bring actually? When it comes to those countries that are not necessarily so mature yet, this regulation also gives them an opportunity, I mean, on physician and nurse level, also to get better equipment. When you think about all of the regulations around electronic health record systems and all of the funding that is coming with it. It is under there when it comes to primary use of health data. So to motivate those countries that with this regulation, you can really develop those electronic health record systems to enable the physician and the nurses' work, and for most, the continuity of care. That is, of course, one of the most key elements. And when it comes to secondary use of health data, from university hospital level as head of patient safety and security, I could clearly very well see that the motivation to produce the data around quality and patient safety, as an example, it is also a type of secondary use of health data. So as soon as the physician or nurse can see the data, what does it bring for them also? That is the motivation, and they were, for instance, when it came to infection data, so they were very willing to bring the infection data. And this is, of course, from hospital level, but there are different levels, and Mélodie pointed out those questions, of course, from administrative level. It is different type of issue on governmental level, but on hospital level, I think that you got to explain for the hospital systems also, what is it all about? And then when we come to, for instance, AI tools, again, so really, I mean, so we cannot live without data. If we want to develop those type of very new and innovative tools for physicians and nurses, it doesn't come without data, good data, good quality data. Thank you. Thank
Michelle,
you, Tere.
Michelle, you want to add?
Brief comment. Of course, we could see the EHDS regulation as the whip now. And in a way, you can also see carrots in it with all the good ambitions. But we have to clarify which are the carrots and the benefits that will come out of it, because they are there, actually. And then hopefully there will be a public pressure from the individuals, the patients in the different EU countries, looking at this and saying, well, in that country, they comply to EHDS in a very good way, doing that and that. Why aren't we? So that pressure will also be, well, in a way, benchmarking perhaps, so will drive us towards a more positive direction for all of EU, I would say.
Yes, Aiga.
I would agree to it all. And actually, additional answer to you is that it evokes a new wave of cooperation because hospitals understand, I can't do it by myself. I need to cooperate with Sari because she has better this or she has more knowledge on that. At least in Latvia, we won't have huge carrots as well like elsewhere, but we see that these cooperation ideas start booming, and then you have startups, you have other opportunities. But don't stand alone in that. Start talking and not having it ministry's way and ministry's systems, but to see what's necessary, because it's both way conversation. Hospitals are coming back to us by saying, this could be done differently. So I would say that let's use this window of opportunity that we have by also hearing your knowledge, which is so very essential for that. Thanks. Some.
So we have still a couple of minutes. Lars, you wanted to ask something, but we have to be quick in the answers.
Thank you. I got most of my answers. It's already. I'm Lars. I'm from Sweden. I'm with the Swedish Association for Medical Informatics, but I'm also the acting president of the European Federation of Medical Informatics. And one of the real tricky things I think we face is the semantics. And we really don't understand, and I've been having a great interest in understanding primary use and secondary use, and primary data and secondary data. And when I'm thinking from a clinical perspective, the primary thing is that I don't know about, and I use the secondary to know about it. So it's difficult for us from healthcare to understand this, and you really gave a good answer here when you said that we need to explain for the nurses and doctors why this is necessary. And just to give you a little semantic twist, I used to talk a lot about AI, and it's really a difficult word that also. And I started to tell my doctors and nurses that AI actually stands for additional information. Then it's quite easy to understand, okay, something else I need to do here. I didn't tell them that they need to feed the beast. They need to put all this data into something so they can use it. But for 2 years ago, when I started to really use AI, I realized that AI actually stands for augmented information. And then it starts to be complicated because the secondary things is coming into the primary things, and I need, as a doctor or nurse, to react on that also. And now for the last 6 months, I've been thinking that AI might also stand for augmented influencers. Suddenly, everybody is saying, just use AI and everything will be solved. We hear it from the governments, we hear it from all places here, but will it be? That's really a tricky thing. I mean, we're training our doctors and nurses in a long time, and they know 95% of what they're doing. And when you look at it, what is really happening is that the AI companies is going directly to the patients, saying, please, I will help you, and underneath it stands, but I will not be responsible for anything. So do you see any chances how to actually support healthcare to better understand how they should use this new type of services, and how we can avoid to be the one that feeds the beast, that spend more and more time in front of the computers instead of more and more time on tapping on the shoulder of our patients. Thank you.
So we have to be quick now, because now we are already on the coffee break time, but maybe short comments.
I can shortly comment, like, education is the key for everything. And I do believe that we need to adapt, first of all, like, education in schools, and then at least in the medical university, for the nurses, for the pharmacists, for the medical people. They need to know how to use the simple, at least ChatGPT and other simpler versions. I believe that in the future, every person would need to have like fundamentals of programming. So we need to put more on the education, otherwise it won't be that easy. And of course, not forgetting the current population that are already too late to study in university or school. So a lot of trainings for the current physicians, nurses, and overall population, because we know that people are misinterpreting it and using, and people cannot differentiate AI from non-AI, even images which are like completely fake. So we have a lot to teach about.
Totally agree that education to everyone is the key. I think we ourselves, patients, persons, are the key to this. We need to ask our doctors as well, how does this work? What is used in here? How it may help me, or how may it harm me? So this is all of our responsibility.
I would agree with learning again and relearning. Last year, we launched a specific training course for lifelong learning humanly on technical issues and technical skills. And we got a lot of private companies coming in telling, what is Canva, what is that? And actually, problem was time. The nurses and doctors and administrative staff who participated, they said, I really need to master it, but then I have to rush back to hospital. So what's there for time? And I think that is the question to us. When you have the European health data space in place, what does it leave aside? Like, are there additional 10 minutes for me every morning to do something else? And that's a question we need to be aware that not only societies are aging, but the time is rushing away. And are we saving it up for the best purpose? And that's, I think, a question very valid and open.
Okay, really, we are now 4 minutes taken up for networking and from networking. And thank you very much. So it was wonderful. I think everybody will agree that the discussion was really superb. And I think this is not the last time when we meet here. So we try to make it, because the process, this is not the end of the process. Now it's the start of the process on EHDS, and we see more and more new technology coming in. Thank you very much. Thank you for all panelists and the audience.
Thank you.
Ma võtan korraks. So now it's time for coffee. We'll be back 12 o'clock sharp here and continue with the conference.